Good day everyone. Good day Doc Ben. So I'm Yula Francesca de la Cruz together with Gino Mendoza. So for our discussion today, it centers on the Cryptosporidium parvum, a significant protozoan pathogen responsible for acute gastroenteritis and a notable public health burden. So for our overview, we will be able to discuss the following, which is the epidemiology, the life cycle, the morphologic forms, the laboratory diagnosis, its symptoms, and treatment. So for introduction, Cryptosporidium parvum or the cryptosporidiosis is an illness caused by a tiny parasite called Cryptosporidium. So this parasite is a type of protozoan which is a single-celled organism. So it's found all over the world and it can infect many different animals with backbones and including humans. So when humans get infected with Cryptosporidium, it leads to a diarrheal disease called cryptosporidiosis. So the main symptoms of this illness are the acute gastroenteritis or the inflammation of the stomach and intestines. Also, abdominal pain and diarrhea.
Cryptosporidium parvum is a worldwide infection transmitted through the fecal-oral route by ingesting oocysts from infected human or animal feces. While less common in industrialized nations, is a significant cause of diarrheal illness in developing countries, particularly among malnourished children under 5. A notable outbreak in Milwaukee in 1993 infected over 400,000 people via contaminated water. Studies in Iran showed a 10.8% prevalence in humans with higher rates in diarrheic individuals and children. Research in La Trinidad Benguet identified Cryptosporidium oocysts in 151 out of 856 human and animal fecal samples, with molecular testing confirming 135 or 15.77% as Cryptosporidium parvum. The parasitic protozoan Cryptosporidium completes its entire life cycle involving both asexual or zygogony and sexual or gametony reproduction within a single host, typically enterocytes of the small intestine. Humans become infected by ingesting food or water contaminated with sporulated thick-walled oocysts. Once ingested, sporozoites are released and invade host cells, transforming into trophozoites. These then undergo asexual multiplication, producing type 1 and type 2 merons, which release merozoites to perpetuate asexual cycles. Some type 2 merozoites initiate sexual reproduction, differentiating into male or microgametes and female or macrogametes forms. Fertilization leads to the formation of new oocysts containing 4 sporozoites. These oocysts come in two forms, which are the thin-walled oocysts, which can rupture within the same host, leading to autoinfection, while thick-walled oocysts are shed in feces, remaining viable and infectious for extended periods, thus transmitting the parasite to other susceptible hosts.
Now let's move on to the morphologic forms. So the oocyst represents a critical morphological stage in the life cycle of Cryptosporidium, serving as the both diagnostic and infective form of the parasite. So oocysts are the forms detected in fecal samples, making their identification crucial for confirming a diagnosis of cryptosporidiosis. So for its morphological characteristics, so for its size, Cryptosporidium oocysts are the knot of the minute, measuring approximately 4 to 6 micrometers in diameter, positioning them as the smallest known coccidian parasites to infect humans. So for its size and staining, they are typically round and exhibit an acidic fast property. This characteristic means they retain certain stains. Example of it is zilnilcin, even after exposure to acidic decolorizing solutions, which is a key features for their microscopic differentiation and identification in laboratory settings. While its internal structure, each mature oocyst contains four sporozoites. These sporozoites are the infectious elements that, upon ingestion by a host, are released in gastrointestinal tract and subsequently invade intestinal epithelial cells, initiating the parasitic infection.
Cryptosporidium parvum primarily spreads through the fecal-oral route, meaning the ingestion of oocysts shed in the feces of infected humans or animals. This can occur through foodborne transmission, where food is contaminated by tainted water, infected handlers, or animal manure, with common culprits including unpasteurized dairy and raw produce. Waterborne transmission is a significant contributor to outbreaks as the chlorine-resistant oocysts survive in various water sources. Less commonly, aerosolized oocysts from activities like coughing, vomiting, or contaminated water splashes can lead to infection, especially in immunocompromised individuals, highlighting diverse pathways for human infection.
The laboratory diagnosis of Cryptosporidium infection primarily relies on three main approaches. Microscopy of stool specimens is a foundational method. This involves a wet mount examination to identify the characteristic of 4 to 6 micrometers oocysts, which may appear semi-translucent with a narrow and clear halo. The widely used acid-fast Zilnelsen stain causes Cryptosporidium oocysts to retain the stain, appearing red or pink against a contrasting background. Additionally, the highly sensitive and specific direct fluorescent antibody or DFA staining utilizes fluorescently labeled antibodies to bind to oocyst surface antigens, allowing visualization under a fluorescent microscope. Molecular methods, particularly polymerase chain reaction or PCR, are increasingly employed for their high sensitivity and specificity in detecting Cryptosporidium DNA, even allowing for species and subtype differentiation crucial for epidemiological studies. Multipathogen molecular panels can simultaneously detect multiple gastrointestinal pathogens. And lastly, immunological methods like enzyme-linked immunoabsorbent assay or ELISA detect Cryptosporidium antigens in stool and are useful for screening, while in-rapid immunochromatographic assays offer quick point-of-care results.
So for additional info, the onset of symptoms associated with cryptosporidiosis typically occurs following an incubation period of 2 to 10 days post-exposure to the cryptosporidium parasite. So the clinical presentation is predominantly gastrointestinal, characterized by a range of symptoms that may vary in severity. Key symptomatic indicators include: so first is water diarrhea. This is the most prevalent and characteristic symptom, often severe and prolonged, posing a risk for dehydration. So next is the abdominal pain and cramping. It's discomfort in the abdominal region, ranging from the mild aching to intense cramping, as it results from the gastrointestinal inflammation. So next is the nausea, a sensation of sickness in the stomach, frequently accompanied by an urge to vomit. So next is vomiting, the involuntary expulsion of the stomach contents, which can exacerbate fluid loss. So next is anorexia, a significant reduction of complete loss of appetite, potentially leading to decreased caloric intake and weight loss if the illness is protracted. So next is low-grade fever, a mild elevation in the body temperature indicative of a systemic inflammatory response. So the duration and intensity of the symptoms can differ significantly among affected individuals, with immunocompromised patients often experiencing a more severe and protracted disease course. Now, let's move on the last part, which is the treatment. So, the management of cryptosporidiosis varies based on the host immune status and the severity of clinical manifestations. So, several therapeutic strategies are employed to mitigate symptoms and address the parasitic infection. So, the first treatment, which is the antidiarrheal medication. So, these agents are utilized to reduce the frequency and volume of diarrheal episodes by modulating gastrointestinal motility. So, it is imperative that the administration of antidiarrheal medicine be undertaken only after consultation with a healthcare provider. Unsupervised use may inadvertently prolong parasitic shedding or obscure critical clinical signs, thereby complicating the disease course. Also, we have here dinitazoxanide. It is an antiparasitic compound that has received approval from the U.S. Food and Drug Administration or the FDA for the treatment of cryptosporidiosis. Its use is primarily indicated for immunocompetent individuals aged 1 year or older. In this population, nitazoxanide has demonstrated efficacy in shortening the duration of diarrhea and reducing oocyst excretion. So for the last treatment, which is the antiretroviral therapy or what we called ART. So crucially, for immunocompromised individuals such as those with HIV or AIDS, the cornerstone of management is ART. It doesn't directly kill the parasite, instead it strengthens the weakened immune system, enabling the body to effectively control and resolve the infection, while ART significantly alleviates symptoms and leads to recovery in these patients. It's important to note it's not a direct curative agent for the parasite itself, but rather empowers the host's own defenses. So that's all for Cryptosporidium parvum. Thank you for listening.